Thanks, Lindsay. Okay, so today we're going to talk about differential diagnosis. And I am doing part one. And as Lindsay said before, Dr. Harlan is going to do part two in 2 weeks. And so I'm going to focus more on the medical and kind of genetic and kind of differential. And she's going to focus more on the kind of psychological behavioral. Okay, go ahead, Lindsay. So today we're going to review the core symptoms domains of autism spectrum disorder, consider the differential diagnosis for autism and the related neurological, developmental, emotional conditions that are associated. And then hopefully all of us at the end can implement strategies for developing our own differential diagnosis as we assess and diagnose children in our practices. So this slide shows the core symptom domains, right? We all reviewed the DSM-5 criteria: impaired social communication interactions, and then restricted and repetitive behaviors, or insistence on sameness, sensory processing difficulties. So the overlap right there in that orange yellow oval is autism, right? But what we know is very few children, if any, really just fit in that small little oval, right? There are a lot of other comorbid and co-occurring conditions, right, that overlap with social communication and behavior. Many children with anxiety will have difficulties with social interaction with peers. Children with ADHD are hyperactive and impulsive and have difficulty forming relationships, paying attention to a communication partner. Children with language disorders, so communication disorders, have difficulty with social interactions. And certainly children with global developmental delay, intellectual disability will have kind of overlap with both social communication difficulties and restrictive and repetitive interests. So in addition to that, there's all these associated medical features with autism. So many children have gastrointestinal dysfunction. Constipation is very common. 80% or so of children with autism have sleep disturbances. Motor problems. So many children with autism also have developmental coordination disorder. There's a lot of research that's going on right now in the area of biomarkers, right? What are some early features that we can look at in the infant, time period that are related to autism? And low tone is one that keeps coming up. So that's head lag at 6 months, right? Can be a feature that we see in children with autism very early on. Then there's genetic syndromes, which we'll review today, immune dysfunction, and up to 30% of children with autism also have epilepsy or seizures. So it's really important to keep this in mind. Go ahead, Lindsay. Because this is what it really looks like, right? That circle just keeps getting bigger and bigger and bigger as we start noticing these associated medical features and co-occurring conditions. Okay, next slide. So today we're going to look at the neurogenetic syndromes that are associated with autism, communication disorders, sensory deficits like hearing impairment, visual impairment, look at global developmental delay, and then review the definition of sensory processing difficulty. Go ahead. So there are several hundred genes and neurogenetic disorders that are associated with autism. This is a list from Spark. There was a question earlier in the chat about what do we do, right? How do we get kids in for genetic testing? This is one option. So this is a national research study that is going on. Families can go to the website. I put it in the chat earlier, and they can sign up and enter the study. I do believe they get reimbursed for their participation. And what they ask families to do is submit a sample, right? So a saliva sample, and they are doing the microarray. So this is one way to kind of help families access genetic testing if there are long waits to see for a genetics evaluation. So in the orange, we have all the copy number variants. So 11% of children with Williams syndrome, so that's the 7q, will also meet criteria for autism. 17q11.2 is associated with neurofibromatosis 1. And then the 23q11 DeGeorge is also associated with autism. So these are kind of the more common ones that are going to pop up and that you will likely see in your clinic. Chromosomal differences. So children with Down syndrome often will demonstrate autistic features, but about 18% of them, 16 to 18% of them will meet the criteria as well as a co-occurring diagnosis. As far as single gene disorders, there's a lot of them. So there's Charge syndrome, up to 30% of children will have autism. So Fragile X, so FMR1 gene. So Fragile X is the most common single gene inherited disorder that is associated with autism, and up to 60% of children will also meet the criteria. Landau-Kleffner syndrome, which I'll review in a couple of slides, is associated with the GRIN2B mutation. MECP2, Rett syndrome, highly associated with autism. And then there's also tuberous sclerosis and Angelman and Prader-Willi. Just keep in mind, some of the children that we're seeing, you're going to be diagnosing in your clinic, and other children will be coming to you maybe with a diagnosis. They got it outside of your clinic, perhaps by a clinical psychologist, neuropsychologist in the community who may not actually discuss or recommend genetic testing. So it's important to kind of guide parents through this process. I'll give you a case real quick. So 2 weeks ago, I had a kiddo in clinic who was diagnosed in the community by a clinical psychologist, had not reviewed genetic testing, and that's okay. Came to me for a second opinion. As I was talking to the mother and getting the family medical history, she described that there were 2 other cousins in the family that had autism. And so I asked her what side of the family. She said maternal side. And I said, okay, boys or girls? She said boys. And then I said, okay, mom, dad, so I was kind of just getting a whole history. And okay, I wrote it all down. And then at the end, I confirmed the diagnosis of autism and began discussing recommendations and specifically the genetic testing. And I mentioned the 2 tests that we were going to order, which was Micro and Fragile X. Mom kind of jumped in and she's like, oh, I've been tested for Fragile X. I was like, oh, she said she had done prenatal genetic testing with her daughter. So her daughter was 1 and I saw the son who was 3. And she said, I'm a carrier, is what she said, for Fragile X. And so that led me to believe that she is likely in the intermediate range or perhaps premutation range for Fragile X. And then she said, but my daughter was tested when she was born and she's not a carrier, she doesn't have it. So then as I asked mom a little bit more about the cousins in the family, their mom's sisters, boys. Okay, so I have a strong suspicion that this child probably has Fragile X. And so I really kind of counseled the mom and discussed about, I think this will be helpful in understanding a potential reason why so many family members are being affected. So really important to kind of get a good history, talk to families, and discuss their options. And so she did agree to testing. And so I wish I had the results for you. I don't have them because it's still pending, but just a case to think about as children come to your clinic. Next slide. Landau-Kleffner syndrome is a seizure disorder. It is often misdiagnosed as autism. And the reason being is children experience regression. But the regression looks a little bit different in children with Landau-Kleffner syndrome and autism, specifically around the age. So children with autism, if they do experience regression, it's going to be before age 3, usually from 18 to 24 months, right? So very important to do your MCHATs, right? You're screening at 18 and 24 months to catch those kids who do regress. In Landau-Kleffner, these children end up having normal development at first, but then they experience later regression, usually between 3 and 8 years of age, and peak somewhere between 4 and 5 years. The type of regression looks a little bit different. So in children with autism, it's usually a language and behavioral regression. But with Landau-Kleffner, you see only a language regression. The features of the regression are also different. So language regression in autism with the regression of social skills and the increase of repetitive and restrictive interests and behaviors. And then in Landau-Kleffner, they typically have a loss of auditory receptive language. So understanding, right, language. Next slide. I wanted to talk a little bit about autism and the co-occurring, or Down syndrome and co-occurring autism. So this study was done several years ago, and they concluded that the average age of autism in a child with Down syndrome is about 14 and a half years old. We're getting better. Over time, we've gotten better at screening and diagnosing children with Down syndrome with autism. So it usually ranges between the ages of 6 and 14 years old. And the regression tends to occur a little bit later, around 3 to 6 years old. So I think this is very important to discuss. It just goes to show how important it is to screen children with Down syndrome for autism at the ages that we recommend, right, by the American Academy of Pediatrics. It's very easy to engage in what we call diagnostic overshadowing, right, and blame some of the features of autism that we might be seeing on the Down syndrome or the global developmental delay. But what's important to realize is that a high percentage of these children, right, up to 18% of children with Down syndrome will also meet the criteria for autism, and early diagnosis can be very helpful. Next slide. So this summarizes the behaviors that are not characteristic in children with Down syndrome alone, but are consistent with children with Down syndrome and the co-occurring diagnosis of autism, okay? So poor initiation of communication attempts. So this is the lack of showing, sharing, greeting, giving, lack of spontaneous verbal communication with decreased use of compensatory gestures, signing, facial expression, using those nonverbals. Poor response to name or receptive language abilities with atypical attention, so lack of joint attention, atypical eye contact, poor joint attention and social referencing. They play alone more than than children with just Down syndrome, and they are more socially withdrawn. Frequent repetitive motor movements that are difficult to distract or redirect. We know that children with Down syndrome will engage in motor stereotypies, but again, it's the intensity seems to be greater and more difficult to redirect these children. Decreased imitation of others with more interest in objects, right? The mechanical aspects of what of how toys operate or what they're doing versus the people who are actually using them. Lack of any functional or pretend play, extreme sensory hypersensitivities and self-injurious behaviors. And of course, with any children with developmental regression, it is get a very good history and consider referral to genetics and or neurology for an EEG. Next slide. Hearing impairment and autism. So there are lots of similarities between children who have hearing impairment and children who have autism. So both populations will demonstrate echolalia, language delay, and have minimal babbling. But children with hearing impairment will often use compensatory nonverbal forms of communication, like gestures, okay? Both will be socially withdrawn or demonstrate social isolation, but children with hearing impairment will make eye contact. They tend to look at their communication partner intently and look maybe more closely at their lips, and they use facial expressions. Both will under-respond to their name, but children with hearing impairment will respond to all stimuli, okay? So I'll give you an example. Many times families that I interview, they'll say, oh, he never responds to his name, but the garbage truck pulls up every Friday and he runs right to the window and he knows the garbage truck is there. Or I turn on the TV and put on his favorite show and he runs like all through the house and goes right to the TV. So these children are not responding to the name, but they are responding to other sounds, right? Other preferred sounds. So those would be more, again, children with autism. Play is also very different. Well, similarities are they play alone, but children with hearing impairment will still have good imaginative play or pretend play. Next slide. For children with visual impairment and autism, both will have echolalia, but children with visual impairments will, again, rely on nonverbal communication strategies more so than children with autism. Socially, both will lack typical social interaction and decreased joint attention. Children with visual impairment will often use active touch during interactions, especially with parents, right? They will feel around and use their sense of touch more so than children with autism. Joint attention, so both will have some decreased joint attention, but joint attention often can develop and grow and expand in children with visual impairment. So it's delayed and tends to get better over time and with their caregiver. Play, both populations will play alone or only with a few toys or play repetitively with the toys. Children with visual impairment will choose more exploratory toys, toys that have more tactile input that they can get out of it, musical toys, colorful toys, or toys that have color contrast. Both children will have stereotypies or the need for sameness and predictability. They prefer routines and structure. Children with visual impairment often engage in what we call blindism, so they will kind of repetitively rub their eyes or for that pressure, and then also they will gaze at lights, okay? And these tend to decrease over time, but they may look like the child is stimming. So, next slide. So communication disorders. So when I like to look at communication disorders, I like to look at them in two different kind of categories, speech disorders and then the language disorders. So speech disorders are divided up into speech sound disorders. And so that includes phonological disorders, articulation disorder, dysarthria, and childhood apraxia speech, which I'm going to talk about, hoarseness, hypo or hypernasal speech disorders, and then disfluency or stuttering. And then we have our language disorders. So pragmatic disorders, semantic disorders, and what we'll focus on today, because these are going to be the bulk of what you guys will be seeing in clinic, is receptive expressive language impairment. Next slide. So for children with childhood apraxia speech, so these children typically have a good understanding of language and they know what to say. What they struggle with is the planning and the sequencing of complex movements necessary to produce intelligible speech. So the brain knows what to say, right? But the child has a hard time getting the sounds out properly through the mouth, right? So the example I like to give is the word buttercup, okay? So if you say the word buttercup several times, and everyone's mic is off, so you can just practice right now. You say buttercup, 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 okay? It's a 3-syllable word. Each syllable starts with a different sound, okay? So it starts with B, okay, the B sound. If you look at my lips, right, B, it's a bilabial sound. It comes from the front of your mouth. Tur, tur. comes from the middle, right? So that's you're using your tongue, right? You're pressing it up against the front of kind of the ridge of your teeth, and then also the sides, and you're making the sound. And then cup. Cup comes from the back of your throat, right? It typically is when the back of the tongue is touching the top of your mouth, the soft palate, okay? And Jamie's on, and I'm not a speech therapist, so Jamie, if I'm wrong in any of this, you can always jump in. But anyways, so in order to make those sounds come out correctly and sequence them, it takes a lot of coordination, right? Buttercup, 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 buttercup. It's a lot. It takes, different muscle coordination. It takes your breath and timing and everything to make it come out right. And oftentimes what happens is kids with childhood apraxia speech, they get it wrong. They can't sequence the sounds perfectly, and it comes out different every time. Once in a while, they get it right. And they'll say like spaghetti, and you're like, where'd that come from, right? Or they'll get buttercup out right one time, but then they often make mistakes. It's similar to the example I like to give is a golf swing. So sometimes kids, just like I play golf, sometimes you hit it right down the fairway, right? It's perfectly straight, spot on, right towards the green. And oftentimes you're hitting shanks and slices, and that's kind of the kids with apraxia. They're often kind of just off, right? They just can't hit it straight down the fairway. So many times children with childhood apraxia speech get misdiagnosed or misunderstood as autism because they are struggling so much with communication. And there's a lot of communication breakdown, and there's frustration, right? They get very angry and upset and dysregulated. Keep in mind that children with autism often present with childhood apraxia speech too. I think this diagnosis is missed very much. Again, we talked about diagnostic overshadowing before. It's easy to blame everything on the autism, right? Versus also looking into other, comorbid speech and language disorders. So childhood apraxia speech can happen on its own, but it also can happen comorbid with autism. Main differences between childhood apraxia speech and autism is children with apraxia speech have better receptive and expressive language skills, and they compensate more with nonverbals. Next slide. Mixed expressive receptive language disorder. So expressive language disorder is the output, right? That's what we're able to say and communicate. Receptive language is the input, what we understand and receive, okay? Expressive language is when children use speech, writing, signs, gestures to communicate their wants, needs, and thoughts. Receptive language is a child's ability to understand, right? Language, words, gestures, and their meaning. So it's the ability to understand nonverbals as well, right? Expressive language disorder is when a child has difficulty conveying information through speech and other forms of communication. Receptive language disorder is when a child has difficulty with language comprehension, understanding what is being asked of them. So what can you look for, right, as a provider? So children with expressive language disorder will have a limited vocabulary, so fewer words. They have difficulty using words to express wants and needs. I want milk. I want to go outside. They have difficulty combining words to make sentences and might just kind of stick to single words. Difficulty telling age-appropriate stories. With receptive language, they have difficulty following directions and answering questions like WH questions or yes/no questions, and difficulty understanding what's read to them. Next slide. Many children will present with both, especially the children that we're seeing, and that you might consider doing a stat on because you have concerns for autism. The difference is children with mixed expressive receptive language disorder will typically engage in appropriate eye contact. They'll respond when their name is called. They'll imitate sounds, actions, and expressions of others. They'll use nonverbals, right? Those gestures and facial expressions to communicate. Smiles, frowns, furrowed brows. They can show you when they're angry. They often point or show objects of interest to others to share enjoyment. They have typical patterns of language development, and they engage in pretend play, right? So they have imagined play, and they can use objects to represent something else. Next slide. Sensory processing difficulties. Okay, another word for this is sensory modulation dysfunction. So sensory processing disorder is not a standalone diagnosis. There was a policy statement published by the American Academy of Pediatrics in 2012, and the conclusion was that there isn't a consensus of whether or not sensory processing disorder is a standalone diagnosis because there is not an agreed upon framework. Okay, so it is not in the DSM-5. It is considered more of a symptom or a sign of something more, and it warrants further investigation. So many times children very young will present with sensory processing challenges, and they go on to have autism, right, perhaps, but many go on to have developmental delay, anxiety, ADHD. And so it's important to kind of just dig a little bit deeper and ask families questions and figure out, is there something underlying, right, with the sensory processing challenges that they have. The prevalence is very high, between about 5 and 16%. And again, we've already talked about this, but these are kids who are hyposensitive to certain things, so they seek out stimuli and input. And then there's children who are hypersensitive, who avoid and are defensive towards sensory input. But many children, there's overlap, right? They experience both hyposensitivities in certain areas and hypersensitivities in others. Next slide. Global developmental delay. So this is a diagnosis where children are delayed 2 standard deviations below the mean in at least 2 developmental domains. So one thing I didn't ask earlier about the case, and I just remembered it now, is ages and stages wasn't done. So that I don't think the child had anybody administered a multi-domain screening tool with this family. So we want to look at the 5 areas of development: cognitive functioning, so problem-solving ability, speech language, receptive and expressive, language motor, so gross and fine, social emotional, and adaptive, are activities of daily living. So when children have delays in 2 or more areas in those 5 categories, right, and 2 standard deviations below the mean, that's when they meet the criteria for global developmental delay. The prevalence is pretty high, so it's 1 in 3% of children. Next slide. This diagnosis is used for children who are too young to participate in standardized testing, so usually under the age of 5, okay? And it most often will also include a deficit in the cognitive domain, so cognitive impairment. We do more developmental testing when children are young, and developmental testing tends to be less predictive of IQ testing and long-term outcomes. So IQ and adaptive assessments tend to be less reliable when we do try to use them on younger children. And not all children with global developmental delay will go on to have intellectual disabilities. So it's really important that we follow these children over time, right? And then refer for additional testing, if we think that that diagnosis needs to be further clarified. 8 or 9 years old is a great time to maybe refer to neuropsych. These children, many of our children that we're seeing, will be in the school district, and they will be eligible for a 3-year reevaluation and assessment. So you can look at the cognitive testing that's done through school to get more information as well. Next slide. Oftentimes, children with global developmental delay will have delays in social communication. Remember, these delays need to be less than what would be expected for the developmental level, okay? They also sometimes have autistic features like stereotypies or repetitive behaviors. And as I mentioned, many will go on to have intellectual disability, but oftentimes kids may present later on with learning disabilities, speech and language disorders, ADHD even can be, a later diagnosis. Next slide. So the overlapping features between autism and global developmental delay, both will have difficulties with communication, motor skills. Motor skill delay can be a common feature amongst both. Cognitive challenges, so problem solving, challenges in social interaction, and then behavioral patterns. Next slide. So how does this all fit together on kind of a developmental trajectory? So age of diagnosis is on the x-axis, and then you see the diagnoses on the y-axis. And so many of these disorders, we have a good idea of when the symptoms are going to emerge and begin to present, right? Global developmental delay is one that is really identified across a lifetime. So sometimes children are not picked up very early because they have more milder delays, and they're picked up a little bit later by the school. But usually you can, with proper screening and surveillance, you can really identify these kids pretty early on. Autism, average age of diagnosis of autism is around age 4. We're getting better at diagnosing kids younger and younger now, which is great. But again, these are neurodevelopmental disabilities that are going to present early on in childhood. ADHD, a little bit later on, right? When kids start school, 1st, 2nd grade, we're starting to notice those kids who are fidgeting and moving around and can't sit still and pay attention. Then anxiety, mood disorders, and other kind of mental health disorders as well. And so I think this is a great slide that kind of segues into the next talk that we're going to have with Dr. Harlan. She's going to focus more on kind of those anxiety, psychiatric, and behavioral comorbid conditions that often occur with autism. Thank you.
Great. Thank you so much, Amy. Let's open to questions. We've got about 4 minutes. Awkward silence is okay.
I have a question.
Great. Thank you.
This is Dr. Laverne. So, when should we do genetic testing? Is it really only if there's any family history of autism or any other any possible genetic disorders, or should we do it on everyone?
Well, genetic testing, the American Academy of Pediatrics recommends genetic testing on any child with global developmental delay and autism. So that would be my recommendation. You're not going to do it on every child, but for children with the global developmental delay diagnosis and autism, absolutely, I would refer for genetic testing. Access to genetic testing is a problem, right? And there's been some chat today about what do I do? How do I get them in? Angie, did you mention, I think, about, okay. Yes, so our genetics team is very overwhelmed. They have a 2-year wait. And so they are not seeing children with just autism anymore. So when you are referring, if you have a child with, as we discussed today, one of these comorbid co-occurring conditions, right? It's really important to put that in the referral, okay, so that they know. So if a child has autism and global developmental delay, which is going to be the majority of children that you guys will be diagnosing, right? These are going to be children with level 3 autism. They will likely accept that referral, okay? And other diagnoses like seizures, they will accept. The intellectual disability diagnosis, global developmental delay, macrocephaly, so enlarged head circumference, they will accept. And there's a few others. I think just in the near term, we're going to try to work out how we can optimize e-consults to help support primary care providers in their efforts to get genetic testing done. I mentioned the SPARK study is a great way for families who may not be able to get in to see our geneticists. That is, like I said, a national.
I'm sorry. With the SPARK study, do they give back results?
They do. And typically what happens is the results will go back to the primary care provider. So you do need to be a little bit involved in that process with the family. But many families are able to get the genetic testing done sooner, much sooner than waiting kind of the 2 years to see an actual geneticist. So I think it's a great option. And it's actually, they provide a lot of really wonderful information on their website to support families just in general. So it's a great resource if families are interested.
Thank you.
Yeah. Elena?
Well, I was curious about that, and I know we're focusing a lot on our younger children, but so what about primary care providers who maybe have a child that's new to their practice, who's older, who has autism, has never had genetic testing, and maybe is not appropriate for developmental pediatrics due to age? How do you help families navigate that? I'm kind of speaking from a personal, professionally, kind of sometimes is coming up with my families who have older children.
Yeah. So, and you're talking about genetic testing, like how can we get that? I mean, you can always refer to the SPARK study, like I mentioned, but I would absolutely refer them for genetic testing, even if they've never had it done before. I often tell families, genetic testing changes very rapidly, right? It's always changing. So many times if you do a microarray, the lab will rerun it for free 2 years later because the panel has changed, right? Just in that short period of time. It's kind of like your cell phone, right? Your cell phone, is evolving and changing every year. There's like a new feature, right? And that's the same thing with genetic testing. So the genetic testing I'm ordering now on patients is not what I was ordering even when I was in training, a little while back. But so it's always so for many kids, even like reevaluating like later on and following up with genetics like 5-10 years later, I think would even be appropriate. So for those kids who are getting a later diagnosis, I would still consider doing genetic testing on them.
And just make a case for the primary care to go ahead and put in that referral or something like that. Just thinking for
I see what you're saying.
Care provider folks on the echo. So, okay.
Yeah. I mean, ultimately it's up to the families. I leave it up to them. It's not a requirement. It's not something they have to do. I talk to them about, if they want to have more children, it's helpful for family planning. If anybody else wants to have children, like the child with autism might want to have children someday, your child might, or a sibling, right? So it's sometimes nice to just have additional information and to be able to plan ahead. So those are some reasons parents do it. And then I have a large population of families who opt never to do genetic testing at all.
Great.
It's a very personal decision, I think.
Earlier, we also put a link in, we had a genetics presentation a couple months ago, and so that link is in the chat for that presentation recording. So thank you so much for all of the learnings today. Quick reminder that to claim your CMEs, you do need to go back in our system. Hong Yan has put some information there. You need to do that by 8 a.m. on the morning of our next session, which is May 23rd. So the topic will be exploring differential diagnosis and autism part 2. Thank you, Elena, for being our knowledge burst presenter later on in May. We hope to see you then. If you have any questions or comments, reach out to me, and otherwise, take care. Thank you so much.